Hello, everyone, and welcome to the GAPP MASLD MASH Community Network meeting with Christina Hanson. My name is Lauren, and I will be your moderator today. I am joined here virtually by our presenter, Christina, and there will be an opportunity to ask questions live at the end of the presentation. So hold your questions until then, and now I will pass it off to Christina Hanson.
Thanks, Lauren. Welcome, everybody. We are running a series over the next several weeks on MASLD and MASH on our individual community network hubs. And so I appreciate you joining me today. This will be recorded and enduring material on each of our sites that you can reference later. But let's go ahead and jump right in. Today, I'm going to be talking about lifestyle management as it relates to MASLD and MASH. And we're going to go through a patient case, a pretty common scenario of what we see in our clinics. So we're going to interweave that throughout my talk today. So again, as Lauren said, I'm Christina Hanson. I'm a nurse practitioner at South Denver GI here in Colorado. I've been practicing at South Denver GI for a little over 18 years in general GI and hepatology. We also have a research department, which is predominantly liver, and of course, these days, predominantly around fatty liver. So if you have a chance to grab this QR code, you can register for this meeting. And again, you will be able to access this lecture later on my network. This is a program that's promotional and put on by Madrigal. It's a disease state education. You can visit the GAPP MASLD MASH Community Network to view Madrigal MASH disease state education and Madrigal Resmetirom promotional program. And again, you can use this QR code here for that. So let's go ahead and jump in and talk about a common clinical scenario that we see in our practices frequently. So this is Albert. He is a 65-year-old man coming in with a history of obesity. A very classic scenario where he was referred into the practice for findings of elevated liver enzymes and abnormal imaging. His abdominal ultrasound was notable for increased echogenicity, which we know our radiologists review and say is consistent and suggestive of steatosis. So again, very, very common scenario. We typically see patients that are referred in for one or the other or both as incidental findings, maybe during annual exam lab work, or they get an ultrasound for something else, such as evaluating their gallbladder. And incidentally, it shows steatosis. So Albert is a 65-year-old Hispanic male. We can see some of his stats here. His BMI is 29. So he's just right on that cusp of obesity, overweight obesity. And some of his blood work over here that prompted this evaluation. His triglycerides, 89, HDL 41. He does have a history of hyperlipidemia. His hemoglobin A1C is 7.2%, so it's definitely elevated. He does have a history of type 2 diabetes, so looks like he might need a little bit better diabetic control. And his ALT he has a history of known elevation for the past handful of years, at least 1 to 2 times the upper limit of normal. Now, when we are evaluating Albert, we want to make sure, we know already that there's an underlying liver condition, right? Based on ultrasound imaging, we know that there's steatosis, there's fat in the liver. But people can have more than one thing going on. So you want to make sure in this scenario, whether it's simply the steatosis on imaging in the absence of elevation of liver tests, in Albert's case, he does have a history of transaminitis, or with elevated liver enzymes, we want to make sure we're ruling out other underlying liver conditions. So getting those autoimmune markers for autoimmune hepatitis or genetic markers for PBC, making sure that we're evaluating for iron overload, getting those viral hepatitis serologies. So making sure, again, that's not the exhaustive list, but we're getting these other markers to make sure all we're dealing with here is steatosis. And let's not forget to ask about alcohol. So certainly alcohol can elevate liver enzymes, but certainly it can lead to development of steatosis or fat in the liver. So making sure we're asking all our patients about their alcohol history. And when in doubt, we do phosphatidyl ethanol testing in our practice, PEth testing, really on all our patients, regardless of their of what their statements are when asked about their alcohol use. And the way I explain that to my patients is it's just our standard evaluation. I validate what they're saying as far as when questioned about alcohol, but part of our standard, just like testing for viral hepatitis, HIV, etc. These are just markers that we want to follow over time and have as baseline. So Albert is reporting no alcohol since his 20s, so we can feel pretty confident that he does not have MASLD or alcohol related fat in the liver. Here's his medical history, again, very standard for metabolic syndrome. He has type 2 diabetes, hypertension, and hyperlipidemia. And again, on a physical exam, he does have abdominal adiposity, but no stigmata of advanced liver disease. So no evidence of spider angiomata, pulmonary erythema, asterixis, jaundice, etc. Things that would be more concerned with advanced liver disease or cirrhosis, of course. And again, that BMI, again, being right on that cusp of overweight, obese. So again, we feel quite confident of a diagnosis of metabolic dysfunction-associated steatotic liver disease. And we call that MASLD. That's kind of the overarching umbrella of metabolic driven fat in the liver. And that's that change in the nomenclature that we've seen over the past few years from calling it NAFLD or NASH. Now we are referencing this as MASLD and MASH. All right, so let's break this down further. So the MASLD care pathway is what we're going to talk about next. And really, this is a clinical care pathway that can be utilized in the primary care setting as well as GI, our endocrinology partners. And it's how we go about identifying patients with MASLD or MASH these days. So rather than waiting to find incidental findings of steatosis on ultrasound, or for those liver tests to be elevated, we want to be looking at our patients in front of us and identifying them based on risk factors. So if patients have type 2 diabetes or obesity, right out the gate, we want to think about fat in the liver because those two metabolic comorbidities are significantly associated with MASLD. Or if a patient has two or more metabolic risk factors, again, that might be hyperlipidemia or hypertension. Again, you're going to be starting to think about this patient is at high risk for fatty liver. I want to screen this patient. Of course, if we have a patient with elevated liver tests or steatosis on imaging, that obviously is going to take us through these next steps as well. So getting that history, as we talked to Albert about, is there any excessive alcohol intake? Another thing that I typically want to be talking to my patients about is the potential for certain steatotic or steatogenic medications. There are medications that actually can create fat in the liver over time. And it's not necessarily referenced on this algorithm, but just for you to keep in the back of your mind as well. Long-standing use of methotrexate, amiodarone, tamoxifen, chronic steroid use. These medications can actually, over time, create steatosis in the liver. So making sure we're ruling that history out as well. Getting some additional blood work as we see here in step 2. And then, of course, we want to understand. We can't really see by the lab work that we're baseline and lab work or the imaging if there's any degree of fibrosis. So we certainly need to stage this individual's potential for fibrosis. And when I'm talking to my patient about that, no matter what the liver disease is, right? Fatty liver, hepatitis C, iron overload, we want to make sure we understand, has that condition caused any injury or what we call fibrosis? And that's, of course, when we're talking in layman's terms to our patient. So non-invasive testing for fibrosis. And really that down and dirty first triage in the primary care endocrinology setting is that FIB-4 calculation. And that's based on a patient's age, AST, ALT, and platelet count. Super easy to calculate. It clearly has its limitations, not a perfect tool, but it really is useful for that very first triage because it's so simple to use. So we break that down. A FIB-4 of less than 1.3 really is a patient that has low risk for advanced fibrosis. We can feel fairly confident in having those patients stay with their primary care endocrinologist, but repeating that non-invasive test, repeating that FIB-4 every 1 to 2 or 2 to 3 years, pending that person's other cardiovascular or cardiometabolic risk factors. Okay. So repeating that non-invasive test periodically and obviously controlling those other cardiometabolic conditions, their diabetes, their high blood pressure, or the high cholesterol. So that patient we can kind of keep in the pocket of our primary care cohort. But then with a FIB-4 of 1.3 to 2.67, that really falls into this kind of big range of indeterminate risk. And so we really want to do a secondary or sequential fibrosis test with that. And really our guidelines, our updated ASLD guidelines recommend FibroScan or elastography techniques to measure the stiffness of the liver. And there's various tests that can do this. We know vibration controlled elastography technique tends to be the most common if we have availability in our area. So again, breaking that down further in step 4, a liver stiffness measure that's less than 8 kilopascals, and that's the measurement of stiffness of the liver. That's a low risk patient. Again, we can put them back into that monitoring, repeating that non-invasive test yearly or every couple years. If we have that patient falling into a moderate risk range, liver stiffness measurement 8 to 12 kilopascal, this is where we want to refer that patient to the hepatologist for further staging and management. And then, of course, a FIB-4 that's greater than 2.67, that is concerning for more advanced or at-risk MASH, at-risk fibrosis. So that's an individual, again, that really should be referred on to our hepatology partners. So let's talk a little bit more about some of Albert's blood work. So we see his blood work here. ALT 43, AST of 38, platelet is normal. Low platelets is probably one of the most cardinal synthetic liver function marker. We do think of it as a liver test along with albumin, bilirubin, AST, ALT. A low platelet really should put a flag up for advanced fibrosis and notably cirrhosis. So a lot of these patients first get kicked over to the hematologist, right? But I want providers to think, when I have a patient with a low platelet count, I've got to be thinking about cirrhosis in this patient. So just a teaching moment there, but normal platelet. Another teaching moment is the ratio of AST to ALT. So when we see the AST greater than the ALT, there's two things to think about. ASTs that are greater than the ALT, you think about alcohol, heavy alcohol use. That's going to be a flag for you to think this patient may have heavy alcohol use or advanced fibrosis, cirrhosis. When that AST rises above that ALT, those are the two pockets of scenarios that you think about: alcohol use versus advanced disease with cirrhosis. But we can see that Albert's ALT is a little bit higher than his AST. He does not have that inverted ratio. And his FIB-4, 2.22. So he really does fall into that indeterminate risk category, which is a really large category we can see with those numerically. So what do we want to think about next? So we talked about how this is really where we want to do a secondary sequential non-invasive test. And we did the FibroScan, elastography, and he ended up falling in that low risk category. So we're going to put him back into management with his endocrinologist and his primary care, managing with lifestyle modification, getting those cardiometabolic diseases well controlled, and then following up periodically to repeat those non-invasive tests. So here's that MASLD continuum. We talked about how overweight or obesity and type 2 diabetes really are those two cardiometabolic risk factors that you want to think this is a high risk that this patient has coexisting fatty liver, and we want to screen this patient. So if they have overweight or obese, or they have type 2 diabetes, think fatty liver. Or if they have 2 or more other metabolic derangements like high blood pressure, high cholesterol, you think about screening these individuals. And then with these metabolic conditions, of course, they have some degree on the spectrum of MASLD, whether it's bland steatosis only, so just fat in the liver, versus fat with inflammation, ballooning of those liver cells, and then moving on into those stages of fibrosis, even into cirrhosis. We know the vast majority of patients, as I tell my patients, kind of live and die with their fatty liver. So it's not liver-related mortality or morbidity or cirrhosis that necessarily gets them. It's about anywhere from 15 to 20, a little over 20% of patients with fatty liver that it actually advances to cirrhosis. But because it's such a large, such a massive, no pun intended, disease, that's why we see it has become the #1 need for transplantation of the liver, notably in women with men shortly thereafter, because again, it's such a vast majority of patients that have fatty liver, you're going to have a higher percentage of transplant listings for that. So again, not the majority that advance to cirrhosis, but what is important is the risk of cardiovascular disease. Even with simple fat in the liver, these patients are at risk, a higher risk, heart attack, stroke, etc. So along this spectrum, in the old days, we really thought this was fixed, that you were not able to, once you moved into these different stages of fibrosis, there was no reversibility. But what we've learned over the years is that the liver is a really hardy organ. You know, if you think about transplantation, live donor to donor, you can lop off half a liver, transplant it in somebody else, and both of you can grow a portion of liver back. It's very regenerative. So if we can take away that offending factor, and notably in the setting of fatty liver, if we can improve the fat in the liver, we can actually get improvement in liver health. We can actually reverse even fibrosis. We think that maybe even into early cirrhosis, there's some ability of the liver to regenerate. We just really don't know where that point of no return is. But there is reversibility. And we do see this with liver diseases, that there's a back and forth as time goes on in this progression and reversibility. Obviously, the kind of big risk we have once, especially we develop cirrhosis, is the development of HCC or hepatocellular carcinoma. There's a very, very small percentage of patients that in the absence of cirrhosis with fatty liver that can develop HCC. It's a very, very small percentage though, but it is possible. So this is a busier slide. We recognize that the pathophysiology and pathogenesis of fatty liver certainly is complex. There are many, many pathways contributing to the pathophysiology and development of fatty liver over time, and the advancement to inflammation, steatohepatitis, and eventually cirrhosis. We're very well aware of, what we're eating. Certainly, what goes in affects us. So saturated fats increase inflammation, reactive oxidative stress is involved with that. So definitely our supersized diets over the last couple decades with high fructose sugary drinks as well, contributing to de novo lipogenesis, decreased fatty acid oxidation, and of course, increasing that oxidative stress. So certainly diet plays a really large role, but we recognize that there are genetic predispositions for patients to have and develop fatty liver and more concerning or severe forms. PNPLA3 is probably the one we are most familiar with, but there are other genetic variants that are related to increased risk of fatty liver and the various negative effects that they can have, again, increasing de novo lipogenesis, decreasing fatty acid oxidation. Toll-like receptor signaling can be decreased, and we can get reactive oxidative species generations. We also recognize certain dietary fats can contribute to the development of inflammation in the liver. Omega-6 fatty acids and notably can actually increase inflammation, where interestingly enough, omega-3 fatty acids actually have a positive effect on lipid metabolism and decreasing inflammation. So clearly you can see there are a lot of different pathways working in concert, leading to the pathogenesis and development of MASLD and MASH over time. So obesity, pandemic, certainly we recognize this is, again, no pun intended, a huge issue that we have not only here in the United States, but globally. And we recognize the high risk of developing type 2 diabetes with obesity as well as MASLD. So remember, having that patient with obesity, you want to think about fatty liver and screen these patients. And of course, diabetes, that's that other very, very prominent condition that we think fatty liver. So, when I have a patient that's coming in with acid reflux, let's say, some kind of condition that has nothing to do with fatty liver, but I look at them physically and I look at their medical history and I see these comorbidities, I want to think about fatty liver and I want to have that conversation. Liver disease in and of itself tends to be a silent disease until these patients become cirrhotic and then decompensated, we really often don't know that they have a liver condition unless, again, that's caught on elevated liver tests. So we really want to flip this script where we're looking at these patients and their cardiometabolic risk factors and screening them, not waiting for them to become symptomatic or cirrhotic, and certainly not relying solely on elevation of liver tests or imaging studies. So think fatty liver when you see obesity and type 2 diabetes, and get these patients screened. So how about the management of MASH? So we really do recognize that diet and lifestyle modifications still are the cornerstone, and there really is a balance between nutrients and energy. This is crucial in developing MASLD and MASH, energy in, energy out. Central adiposity, that central obesity, that round tummy really is a major promoter of insulin resistance. We've recognized this for many years in our diabetic patients, but this is definitely central to the development of fatty liver with pro-inflammatory signaling. And again, insulin resistance is strongly tied with that. So let's go back to Albert. Upon questioning Albert about his diet, he really explains that he eats a traditional Cuban diet consisting mostly of rice and beans, pork, corned beef, and plantains. How can we best discuss diet with Albert? How can we tailor recommendations around cultural preferences and food accessibility? We have to think about socioeconomic status too. We're going to talk a little bit about Mediterranean diet, but I try to explain to my patient, it doesn't have to be all grass-fed organic, and one of the things that I'll start with is what are some simple things that they can cut out at first? My father actually grew up in Brazil and had rice and beans at every meal. It seemed like we could have breakfast for dinner and there was a pot of rice and beans on the stove. And my dad actually had fatty liver. Okay, Dad, can we take this down to maybe 3 days out of the week instead of all 7 days? How can we kind of start to separate that a little bit and phase some of these things out? A lot of it's cultural too. What is your filler on the plate? Well, my rice and beans and my side of potatoes and my bread, that's what's supposed to fill me up. So how do we make those shifts around diet, thinking about those cultural preferences? Can we substitute that tortilla for, a lettuce leaf? But, it's takes a little bit of counseling, a little bit of bringing that patient back in. Hopefully, if we have access to a dietitian, bringing that specialist on as well. But whether it's diet or exercise, what my mantra is with patients is start simple, but simply start. What are the small changes we can make so that it's sustainable, and then work through that over time and not make it this overwhelming process for our patients? All right, so let's talk about that a little bit in a little bit greater detail. So lifestyle modifications, diet, I talked about how this really has been the mainstay and cornerstone, certainly prior to our approval of Resmetirom, the first FDA-approved medication for fatty liver. And it's still approved, Resmetirom's approval is still in conjunction with diet and lifestyle. Weight loss, we know this has been directly linked to improved histologic outcomes, so on biopsy with steatosis as well as fibrosis. In fact, up to 5 to 10% weight reduction can actually resolve steatosis and exert an antifibrotic effect. So we can actually have reversal, especially when we get up to 10% or greater weight loss, we can actually have reversal of fibrosis. But clearly this can be very difficult for our patients to achieve and sustain. We also have recognized that along with lifestyle modifications, certainly the efficacy of diet and exercise may be impacted by genetic polymorphism. So not only are genetic variants and mutations associated with triggering of the disease, development of the disease, and progression of the disease, but may actually affect the efficacy and response of treatment. And there are studies looking into this, notably PNPLA3, we talked about being one of the most common genetic variants with fatty liver. There's studies looking around calorie restriction and how that can actually improve intrahepatic triglycerides, so reduction of intrahepatic triglycerides. So definitely there's a lot more to be done around studying genetics and how that can actually impact treatment response. And so we talk about precision medicine in many different disease states. We may in the future have precision diets when it comes to fatty liver, along with precision medicine around what's going to be the best treatment algorithm for patient individually. And then when we look at exercise, one of the things that I talk to my patients about is the importance of cardiovascular or aerobic exercise and not to get caught too much on the scale and the weight. We've seen studies showing that with regular aerobic exercise, even in the absence of changes in the scale, there can be a reduction of steatosis in the liver up to 30 to 40%. So, patients often want to see those changes and changes soon on the scale, but I try to encourage them to continuing to sustain that and get into those habits. You can actually be reducing fat and not really even know it because you're not necessarily seeing the changes on the scale. Actually, we are all very familiar with the HIIT type of training, high intensity interval training. It's actually been shown in studies to not be effective, and this was recent studies as of 2023. Resistance has not been shown to be superior to aerobic, and that's related to resistance training requiring less energy consumption. So there seems to be a combination of aerobic and resistance, really seems to be the best witch's brew, if you will, of improving NAFLD or fatty liver and reversing, if we can, MASH and being consistent with that. So again, taking into account, especially our men like to lift their weights, and we definitely want that. We want our women doing weight bearing and bone for their bones, weight bearing exercises, but making sure that they find that aerobic exercise that they enjoy and that they can sustain. So again, it comes back to my mantra of start simple, but simply start. There are many patients who've never exercised a day in their life. So maybe walking the stairs or walking the block, just moving, sit and be fit, for some, and then working their way up to getting that aerobic exercise in, and finding something that they enjoy, finding a friend, maybe going to the gym, signing up for classes. Again, it's going to be whatever that patient can do that they can keep consistent with and sustained. So having those conversations around that. And then different diet modifications or ways, I talk to my patient about how we don't necessarily espouse to one diet being better than another, but it seems that calorie restriction, notably reducing carbohydrates, it really can be one of the best things for patients with fatty liver for both weight loss and promotion of ketogenesis. So when we reduce calories and restrict carbohydrates, our body needs a different energy source. So our liver will actually produce ketone bodies from fatty acids within the liver, therefore requiring the liver to store less fat. So we have a different energy source when we're have a carbohydrate starve. And again, that reduces fat in the liver. Again, we talked about genetic predisposition, personal response to specific diet. It's not clearly understood. We need more studies around this, but at some point we may be doing precision diets. And then, as I mentioned earlier, Mediterranean diet really does have the best data in the literature and is supported by our big society guidelines, including the American Association for Study of Liver Disease, our endocrinology, and the European guidelines really recommend this as primary lifestyle intervention. So Albert comes back in for some routine follow-up. He's really had no improvement in his blood work. He admits, though, that he's not begun any exercise and has been trying to cut out soda, but he's obviously not cut it out completely. So again, very common. Our patients, we give them the diet and lifestyle recommendations. They come back in 3 to 6 months or 6 to 9 months, and they're 10 pounds heavier, right? So I think one of the best things is trying to have some degree of accountability and having patients come back a little bit more frequently if they're willing. If we're able to get a dietitian on board for that accountability as well, and having some kind of ways of diet changes and exercise, again, that can be sustainable for these patients. So again, how do we work with patients to create behavior changes? And again, there's not a right or wrong answer, but certainly something that having some form of validation or a clinical tool or bringing these patients in for adherence can be very helpful. So adherence validation. So exercise and diet adherence scale, the EDAS. This is a voluntary prediction system or tool that we can use with our patients. It's a questionnaire that we take at baseline and at 6 months. And it's actually based on a 33 criteria that's checked to monitor their daily exercise and calorie intake. So something that was new to me, but again, having something that's objective that can be utilized in our clinic and for that patient for adherence and accountability can be really helpful as well. So with that, that actually completes my lecture, and I thank you for jumping on and listening today. I want to open it up for any questions if anyone has any questions. But again, thank you for the sponsorship by Madrigal, and thank you for jumping on today and listening in.